Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Hello, everybody, and welcome. I hope everybody's doing great today. I am so pleased because I get to interview a PT, an awesome PT. Hello, Dr. Hope Reyes. How are you?
Hi, doing well. Thanks for having me.
Of course. And do your patients call you doctor? Well, you have little babies that you work with, so they might not call you anything, but do you like to go by Dr. Hope or Dr. Reyes?
Usually Dr. Hope if they use the doctor title. I typically don't use the doctor title with young toddlers and kids because, they get shots when they go to the doctor, or sometimes they're not feeling well when they go to the doctor. So usually it's Miss Hope or just Hope, but a lot of the parents will see my doctor title, so they'll often use it. So I'm good with anything.
That's a good point. Yeah, sometimes the doctor can be scary. Well, let me do your bio and then we'll talk. I have so many really good questions to ask you, so I'm really excited. Okay, so Dr. Hope Reyes is a PT and a doctor of physical therapy and also a certified breastfeeding specialist. She is the founder of Moving Munchkins, which is a practice here in San Diego. Dr. Hope serves patients birth to 5-year-old age range, which is that early intervention age range, that specialty area, which is wonderful. Dr. Hope completed her undergraduate studies at the University of Arizona with a major in physiology and a minor in chemistry. And then she went to obtain her doctorate in physical therapy at the University of St. Augustine for health sciences here in San Diego, graduating with high honors. Dr. Hope has a background in dance, and you love everything Disney related, which is fun. Yeah. I'm sure the little babies that you work with, it's a great match. Dr. Hope is passionate about ensuring that families feel confident about their child's development and wellness. She loves to be part of a collaborative team to offer the most updated and integrative approach to her patients and families. Dr. Hope is trained in several manual therapy approaches to relieve fascial strain within the body for optimal motor and airway development. Dr. Hope brings a wealth of knowledge to her patients and families while providing a holistic approach to meet the family's goals for their children. Thank you so much for being here, Dr. Hope. I know you're surrounded with patients all throughout the day, so I really appreciate you taking some time to help educate everybody about what you do and the role of a PT.
Great. If there's anything else I love doing besides seeing my patients, it's educating. So happy to be here.
That's such a valuable and important skill too, because it's one thing to help our patients, but then to spread that knowledge so other practitioners understand and can learn about the work you do, and also families, because I know a lot of not just practitioners, but also parents listen to this information on this podcast. So this is great. I'm curious to start out with what made you decide to become a physical therapist, and then on top of that, to specialize in working with the infant population and that early intervention population.
Yeah, so I grew up dancing, as you said in my bio, and I was always so confused why a group of us dancers similar in age would train the same, right? We would take all the same classes. And why is this girl able to get her splits or, do something better, arguably, in the dance world compared to this one? And so I would always watch, because a big part of dancing is also observing your peers, or we would watch in the mirror. And I just was flabbergasted at what's happening in that person's body that makes her better or worse or whatever. And so then I grew to realize, not everybody's interested in that, because I thought it was just a natural thing. Everybody's questioning that. And then I was like, I think I need to do this, in my future. So I actually had a couple of dance team dads that were physical therapists. So I shadowed them, I talked to them, and I would always kind of just nerd out with them, I guess. So it was pretty clear to me that I wanted to go that route even in high school. So I knew pretty early on what I was kind of set and meant for. And then when it came to infants and babies, I thought I was going to be working with dancers and adolescents and athletes, which I did a lot at the beginning of my career. But then when I went on my rotation and I saw babies and I was talking to new parents, I was like, I really like this too. So when I got out in the field, I immediately started in pediatrics. I did return to sport, adolescents, post-op ACL. I was working with lacrosse players and soccer players. and which is comical. My husband now is like, you don't even know how to play lacrosse. Like, you know, I never did a sport. I danced my whole life. I was kind of prissy, but anyway, so he's like, you're treating these like really high level athletes. I'm like, listen. So anyway, I did that for a while and I really liked it. But then I noticed that when I would get a little, like an infant trying to crawl or, you know, a baby with torticollis, I'd be like, oh, like I could just tell that was so much more fulfilling. So anyway, long story long, opened my own practice. And now I see that primarily 0 to 5, sprinkle in a couple older kids here and there, but primarily 0 to 5. Yeah.
It's such a specialty skill, though, to work with that early intervention age. I feel like that is the hardest age to work with. I mean, I would assume most practitioners would agree, right? You need really specialized skills to work with babies and children under the age of 5. And even like the babies to the 1 to the 2-year-olds to the 3 to the 4 to the 5, they're all so different. And you have to have engagement and play and movement. Whereas when you're working with an older kid, you sometimes can go like reward route, and like older kids beyond that and adults, it's like they have some intrinsic motivation. So that young age, it's a different skill. So why would an infant need physical therapy?
You know, most often the classic way that like a pediatrician, you know, potentially would refer for physical therapy is torticollis, which means, you know, that one side of the neck is really tight. And my tagline is it's not just the neck, but we'll just go for ease sake of this conversation at this point. You know, the baby has a head turn preference and they're looking to one side and they're having a hard time, you know, with their symmetry of movement. Then they start to develop a flat head. So that's kind of like a pediatric PT's bread and butter. Is torticollis is very prevalent. So we see torticollis, plagiocephaly, brachycephaly, any kind of head shape issues pretty often. And then the other one is just delay of motor milestones. So the child might not have a diagnosis or they might have a diagnosis. You know, we often see kiddos diagnosed with Down syndrome early in infancy because we know that they tend to be behind on their motor milestones. So sitting, crawling, rolling, you know, even as early as head control, you know, before the age of 3 months, all of those types of things. So whether or not they have a diagnosis, they will come, you know, and see us to reach that gross motor goal. So primarily the 0 to 1 age range, that's usually when we're seeing patients is they're delayed on milestones or there's like a head turn preference or head shape issue.
Okay, I'm really curious about torticollis and what that is, how that develops, if the baby's born that way, or what are the causes? And then can you also talk about the different head shape issues that come? And is it because of torticollis or because babies are laid in certain positions? Notice I have like 10 million questions about this. It's really interesting. And I think a lot of people have heard of these terms, but maybe don't know all the details.
Yeah. So basically what we see is if it's there's a couple of reasons why torticollis can really come about. The most common, if there's no medical diagnoses happening, right? The baby didn't have a stroke, you know, around birth, or, you know, there's something called ocular torticollis where one eye is stronger. And so the baby's turning their head so that they can see better. So if those things are not the case, then the most common cause for torticollis is just positioning in utero. They're just stuffed in utero, specifically multiples. This is pretty prevalent in twins and triplets and things like that. But even in single births, this is very, very common. So my whole thing that I tell parents is I could analyze and assess any baby that's fresh out of utero, doesn't matter if they're vaginal or C-section delivery, and they would have asymmetry. It's just some babies are better able to wiggle out their asymmetries and they're not that tight, or, you know, there's not as much fascial or muscular restriction. And then other babies, they really struggle and they are kind of, you know, over to one side and they can't even get to midline, much less their non-preferred side. So torticollis, classified by the American Physical Therapy Association, is asymmetry in the development of the sternocleidomastoid muscle, which is that really big muscle that connects from the back of the head to the sternum and the clavicle. And so what we find when we treat torticollis is it's not just the neck. It's not just the sternocleidomastoid muscle. That's a nice kind of easy way to just like train our PT students and kind of want to blame it on one muscle, but it's not. It affects the entire body. So we look at rib cage mobility, we look at pelvic mobility, we look at scapular and shoulder mobility with torticollis, and then we look at jaw and feeding as it relates to torticollis. At least I do in my practice, and I'm really pushing for more pediatric physical therapists to be looking at torticollis as not just the cervical spine. We do have clinical practice guidelines from the APTA, and they do, talk about, getting more trunk mobility in there. So we're getting there, but we're quite a bit behind when it comes to the clinical practice guidelines and how we're training and educating these new physical therapists on torticollis. We're not yet talking about anything above the cervical spine, but look at the jaw, so I'm like, we got to look at the oral structures. So, when we look at a baby and they're referred to us for torticollis, we really want symmetry of milestones. Strength, development, coordination. They often have a favorite hand that they're playing with. They often have, feeding issues and feeding difficulties. And how can we tease that out and treat that? So, the classically trained pediatric physical therapist will be assessing the cervical spine mobility and strength, and hopefully the motor milestones, rolling is symmetrical, sitting with symmetrical posture, tummy time, and being able to look to both sides. But kind of taking it the next level up, like I mentioned, we're looking at pelvic mobility, we're looking at feeding, we're looking at jaw and airway development when it comes to these babies that are referred to us for torticollis.
And in PT programs, you're saying that the PTs are mostly trained, think of torticollis as neck and sort of neck up, and not even thinking to look at whole body? Interesting.
Right. And so there's a lot of really great continuing education courses that really hone in on looking at the whole body. I was lucky to be a part of one of them and, create one with a feeding therapist, Karin. And so that was a really great opportunity that we have to just put, like you said, we're just going to share our knowledge of this is what we do in our practice. And it's really that holistic approach of we can't just hone in on what we see as the issue, because when I get torticollis patients in my office, I often don't even touch the cervical spine till visit 2 or 3. I'm not even treating that first. I'm treating the pelvic, the trunk, the rib cage, the shoulders. Then I can work my way up. And oftentimes what you thought was torticollis is resolved because we loosened up and we normalized the trunk mobility, or we normalized where the pelvis is resting. So a lot of times the neck is the symptom and it's not always the biggest issue.
I love that. That's so true. It's so common with other injuries too. Like my husband's a physical therapist, right? So other injuries, you got to find the root cause, and patients will have like issue with their hand, their foot, and a lot of it's posture related that starts at the back, or, and it's like, you got to find that root cause. So it's interesting to think about that for little babies too. So,
well, and I think we often don't think about it for babies because they're not in a walking weight bearing. They're not doing impact activities. They're kind of a little blob, before the age of like 3-4 months. They're just laying there and they're totally dependent on us to move them around and put them in different positions. So we're not thinking like, oh, their pelvic mobility is actually limiting their cervical spine mobility because they aren't in a weight bearing position, or they aren't in, these mature posture, and they're not doing jumping and running to maybe give them a pelvic obliquity, right? And so, but it's there because there's a lot of poor positioning in utero that we can't really help, or we can't really do much about until they come out. The other thing that can exacerbate or potentially cause side turn preferences is things like containers, lots of swings, where the baby's head will kind of loll to the side because they don't have the head strength, contraptions and things like that. But usually it exacerbates an already known asymmetry, in my opinion.
Okay. That's actually what's one of my questions is. It sounds like the torticollis, that head turning preference, if I'm understanding correctly, is not just limited to neck and actually may be caused by other parts of the body. Without even having to touch the neck, you can relieve some of that turning preference. And it's often caused by uterine positioning, but it could be caused by other external factors like crates or, positioning that the parents put the baby in. Could it also be caused by positions during nursing? Like if the mother always nurses in a certain position?
What I find with that? I actually find the opposite. I find that parents are so good at making accommodations for their infant's discomfort or inability. So oftentimes what I hear is, oh, baby breastfeeds really well on my right breast, but when it comes to my left breast, I have to put him in the football hold, which, is fine. It's a great breastfeeding position, but they're making accommodations because they're noticing, oh, baby does better doing X, Y, and Z. So I don't often think that the breastfeeding position would cause an asymmetry. I think the asymmetry is already there, and then the parent is just trying to accommodate that asymmetry while feeding.
That makes perfect sense. And so in terms of like putting babies in certain like swings or like containers or whatever, are there recommendations from a PT like yourself as to how to do that to avoid potential head turning preference issues or other compensations like that?
Yeah, most pediatric physical therapists are in agreement that floor time is best. It's sometimes not ideal with all, family dynamics and things like that. But if we're limiting the container, we call them containers, if we're limiting the container amount, then we often find that development can really stay on that linear track that we're expecting and take off, because floor time plus gravity is what really gets the baby moving best. The containers just limit movement from head to toe. Even if their head is not positioned in something, like if you're putting them in some kind of baby bouncer or chair, it's not necessarily limiting the cervical range of motion, but it's limiting pelvic mobility. And if you're limiting pelvic mobility, you're probably limiting cervical mobility or strength or development. So that's a whole rabbit hole. But basically what we recommend is less is more. 15 minutes a day is kind of like, I don't even know if that's truly research proven, but that's kind of what a lot of pediatric PTs have landed on. But what we don't kind of think about is even a car seat is a container. Is it a necessary container? Absolutely. It keeps your baby safe in the car. Is it a necessary container when you need to get fresh air and just go for a walk? Yeah. Your baby needs to be clipped into that stroller. You guys need to get out of the house, get some sunshine. But that's still a container. So we don't always factor in, like, oftentimes the third child is in the container potentially a little more because we're driving older brother or sister, to sports and school and things like that. So they're often in containers a little bit more than like a first child would be.
So we want to get the babies limit container use as much as possible. Can you talk about floor time and what that is?
Yeah, so floor time, we really want to see, I think pediatricians really hone in on like tummy time, which is great. Tummy time is super important, but we often still need to play on our back. We still need baby to reach up when they're laying in supine and use their shoulder girdles and their neck and chest flexor muscles, the front of their muscles, to have hands to midline, to be reach across midline and start using bilateral coordination movements, hand-eye coordination. We also need to be in sideline play. I often give sideline play as something to my babies who are struggling with breastfeeding because they just are not strong and coordinated and comfortable in that position. And that's often the position that mom most often wants to breastfeed in, as they put their baby in sideline and bring them to the breast. So all positions in floor time.
Okay, this is interesting. So I'm thinking now tongue tie, because a lot of things go back to fascia, tongue tie, and how that might relate to torticollis. I've heard that most cases, or maybe nearly all of torticollis, do have a tongue tie component. Maybe that's a broad generalization, but let me know your experience with that.
I think that's a broad generalization only because there are a lot of times where I see an infant in my office, and we know if you're going to diagnose a tongue tie, there needs to be a functional issue or functional concern. The functional concern would most often be at the infant level is difficulty feeding at breast or bottle or both. So there are a lot of cases where I see that the trouble with feeding is position related. It is something in that baby's body is really uncomfortable. It's telling them, this is not a comfortable position. I'm asymmetrical. This is actually my position of comfort. And they're totally like, hanging over, like I call it, I'm a little teapot. And they just like come over this way. They're like, this is where I want to be, not here. And when we resolve the torticollis, or we resolve the asymmetry in the body, and we get the baby strong and coordinated, the breastfeeding issues a lot of times either tone down or they do disappear. With that being said, take my daughter, for example. This is how I got into the airway space. I had difficulty breastfeeding. I had bloody nipples, bruised nipples. Everybody told me she did not have a tongue tie, but she had a lip tie. I just knew it wasn't right. I worked on her, used my skills. I breastfed her fine for a year, fine. So most parents would say there's no functional issue, right? Perhaps if I had a feeding therapist that looked at what her tongue was doing on the breast or bottle, they would say, ooh, that mid blade isn't really lifting. So, it just kind of, I don't have numbers for you. Unfortunately, I have looked at the research up and down when it comes to torticollis and tongue ties. What I can tell you is torticollis absolutely directly impacts infant feeding because the jaw asymmetry and the jaw movement. I don't have research for you about tongue ties. But in my practice, which is still a part of evidence-based, your clinical expertise is still a part of evidence-based practice, I can tell you that there is a really strong correlation between really tight fascia, tight babies, tongue ties, and torticollis. So that is an absolute correlation I see every day. I just don't have research to tell you the numbers.
Interesting. So you do see that correlation. That makes perfect sense. There might not be research or numbers, but tightness, it all goes together, and it's probably hard to differentiate. And there's different factors and compensations and different components. What about the different head flattening? So you talked about plagiocephaly. I'm like, I need to, as a speech therapist, let me break that into syllables. Can you define or talk about what is plagiocephaly, what is brachiocephaly, and how those all come about?
Yeah. So basically, you can have a newborn, fresh out of the womb, with plagiocephaly. It could be that baby had low fluid and wasn't moving around a lot. That baby was a twin birth, and maybe, baby brother was sitting on the, twin B's head or something, or just, small, not that much space in utero because baby's really big. So you can have head shape abnormalities fresh out of the womb for sure. What impacts the head shape the most is what happens after, right? So we are told by the American Academy of Pediatrics to put babies on their backs to sleep to decrease, the incidence of SIDS. So we are putting babies to sleep on their back. The problem with that, when it comes to head shape, is if baby only can look to this side and they're not comfortable looking to the other side, they're just spending so much time on one side. And my kind of tagline is babies' head shapes grow like pumpkins. So if you go to a pumpkin patch, you can see which pumpkin grew laying on its side because it's flat on one side. And so if a baby spends a lot of time, it's pressure over time. If there's a lot of pressure over time on one part of the skull, it will become flat. So that's the same with the baby. I call my little football players that are just so tight. Their shoulders are in their ears. They kind of look around with their eyeballs, but they don't they're just tight everywhere. I mean, there may be a slight asymmetry or a slight preference, but their preference is just to not move. And so they typically develop that brachycephaly, which is flat all the way across the back. So it's a flatter head shape. And when you look at them from the side, you could just tell the back of their head is like a board. It's totally flat. So that's different than the one side and that baby that's very asymmetrical and spending too much time on one side. That's plagiocephaly, where one side is flat.
Okay, plagiocephaly, one side is flat. Brachiocephaly, the back of the head is flat.
Yes.
Okay.
Yes.
Now my brain goes to tone, muscle tone. So I hear a lot of babies these days are born with low tone, maybe not clinically low tone, but lower tone than maybe back in the day. I mean, I've heard people talk about this, but we're also talking about babies with a lot of tightness. So so what happens? Some babies are born with excessive tightness and others are low tone, or do those ever go back and forth in the same baby?
Yes and no. So the phrasing that I like to use, and this isn't really textbook, it's just the way I like to explain it to other providers and parents, is there active tension or passive tension? active meaning when they're doing some kind of activity, whether it's playing on their back or tummy time or feeding, is that baby just fisted and their shoulders are in their ears and they're just really trying to move? To me, that I can't rule out passive tension at that point. Passively, how does their body move? But I can say for sure there is active tension, meaning coordination. Muscles need to turn on and off and be doing a dance, right? So this muscle turns on, then this one needs to turn off and this one needs to turn on. So they often need to be doing a dance and taking turns. When I see a baby feeding like this, I'm like, oh, their muscles aren't taking turns and they're not coordinating to support their oral structures for feeding. Or when I see a baby trying to reach, but they like can't reach, or that baby that's moving their eyeballs and not freely moving their head, they're not able to coordinate their muscles to turn on and off. So then I need to investigate passive mobility, which is me moving the joint, right? Me moving the neck, me moving the pelvis and the ribs to see when the baby is at rest and we're not getting baby to reach for a toy or we're not having baby feed. Is there passive, excessive tension or tightness or restriction in mobility of those tissues that I'm testing? A lot of times it's both, right? But I do often have babies that, the parents will come in and be like, they're just so tight, but they're like chilling when they're in supine. They are not this tight baby. They're just, and I'm moving their arms around. I'm like, oh, they don't seem very tense. They don't seem very tight. So passively, they look great. But when then they go to feed and they are doing this whole thing where their shoulders are up in their face and their hands are fisted and they're feeding. And I'm like, okay, so this is a body coordination strength issue versus a true passive tension issue. When it comes to muscle tone, like you said, there's a huge spectrum. So could we have a baby who's low tone and has extensive tension and tightness? Yes. And so we'll find the low tone when we either relieve the passive mobility and the passive mobility has been restored. And then we see, oh, this baby's, having a hard time recruiting the right amount of muscle strength for this activity. They could still be low tone clinically. And they also could be slightly higher tone. So it's kind of that, I kind of look at it as like a number line, and tone is, can be slightly lower than average, but still can be average. And it could be slightly higher than average, but still can be average. When you get out of the norm, that's where we start to be concerned for, potential diagnoses. But a baby can have poor mobility of the tissues and have that tension, whether or not they have high or low tone.
This is so neat. It makes me think back when my son was born. I thought he was so coordinated. He's advanced because right when he was born, he could like almost sit up. Like you could hold him and his head would be like up in hyperextension, right? Like, yeah, chin up, head up. And then even when he got a little bit older and we did floor time, he was like the king of floor time. He'd like school any other baby. He liked it when he was on his belly within hyperextension. And then I also noticed when he'd nurse, and I nursed him till 18 months, but we had a lot of issues and problems, but we persisted, but there were probably a lot of compensations. But after nursing, he'd go into full torso and neck hyperextension, like pain from maybe reflux. So what is that? Like if he's so hyperextended, it's like, is it maybe excessive tone or coordination? Or I know it's probably hard to diagnose, but I know somebody else I talked to had a similar thing with their baby with that neck chin upwards. Why would that happen?
So the analogy I like to use is we live in San Diego, so we have access to a beach. But when you go to the beach and you sit in the sand, what do you do if you just sit directly in the sand? You kind of have to like swivel your booty around, right? To get the sand to kind of flatten out or at least mold to the curvature of your glutes, right? So that's how babies feel when they're born. They feel like they're sitting on a lump of sand. And the reason for that is their body asymmetry or their body tightness or tension just from being in utero. And again, some babies shake it out faster than others. Some babies don't. So my questioning, I guess, for your son would be, is he trying to scratch an itch? Is this just for some reason the position that makes him feel like he's not sitting on a lump of sand? That would be my first question. My second question would be, is he trying to open his airway? Is suck, swallow, breathe pattern really difficult for him for some reason while nursing or just while in supine? Because we know in supine that changes, the structure of the tongue and the palate. Gravity plays a huge role, right? And my third would be reflux. So those are the things that, as a provider for me, because I have my CBS and I do treat alongside with lactation consultants and IBCLCs, really difficult breastfeeding, behaviors or issues or difficulties, we have to try to tease that out. So my first goal would be to restore really good passive mobility, improve the coordination, and see, is it just him scratching an itch and saying, oh, it just feels more comfortable here. This normal posture feels like a stretch. It feels like I don't know where my body is in space when I'm in this like more flexed posture. So a lot of times if these babies keep arching, when you actually bring them to neutral, or even the asymmetrical baby, they're over here and you bring them to neutral, they're like, whoa. Some of them even startle. It elicits a Moro reflex because they're like, I've never been in this position before. It's really uncomfortable. It's very foreign to me. So we have to show them what true, like, not upright posture, because they're not sitting yet a lot of the time, what true neutral posture is.
And I wonder if other PTs who work with this early intervention age group and the infant age group also think not just stability, but also airway reflux, or do you think you have that special like lens because of the specialized training and understanding you have of airway?
I would say most pediatric PTs are not aware that this could be an airway reflux, or, they're thinking, oh, tone, because that stems from our education. And I used to be in academia. I used to teach in a DPT program. So I can say this with confidence, and it's no fault to them. They teach to the exam. We have the National Physical Therapy Board examination, and they teach to the examination. They don't have the time or the resources to really, go into more depth or detail. Plus, let's be real, pediatrics is kind of the stepchild of physical therapy school. we are not the focus. So, I think that most pediatric, and we should be talking about airway with all ages, but, there is no mention of airway. The only airway knowledge we get is diagnoses. Oh, cystic fibrosis. Oh, now we know airway, right? But it's not this upper airway that we talk about as it relates to, dentition and in the palate and where the resting tongue posture is. So we're not getting that education. You basically have to have a special interest. And all of my colleagues that I've talked to that are pediatric physical therapists that are kind of like honing down and niching, this is their niche. They've have lived experience as a parent. And I know you have too, Nicole. So I have too. And this is what kind of drove me down this road of, oh my gosh, like I said with my daughter earlier, my hands helped her to feed better. But like there was obviously still, she clicked the whole time she fed. So clearly the mid blade of her tongue was not suctioned to the breast or bottle, but compensations galore. But we made it through, kind of what you said. Like I was able to make a direct impact on my baby's ability to breastfeed and bottle feed with conservative physical therapy management. So to me, that was a light bulb. I don't think most pediatric PTs even know what we're talking about when we say airway.
It's so crazy. I mean, that's kind of across the board we find now in so many fields where it would be so pertinent, imperative for that field to know about airway, and it's lacking, right? Orthodontics, a lot of dentistry, PT, speech therapy, OT, but it's growing. People are beginning to learn from all the work you do, the trainings you do, the courses, us getting this information out there. But it could be detrimental when you're not aware of the airway component and you're just treating what you know, right? The posture, the tone, and not thinking there might be a reason that the baby's in hyperextension because they're trying to breathe better, or they're having pain from aerophagia, swallowing air during nursing. It's hopefully that'll get into PT schools over time.
Even if it's like, I just picture like a guest lecture, right? Like I remember in PT school, obviously this was a while ago because I've been practicing for almost 12 years, but we had like a 2-day guest lecture on pelvic health and women's health. And that was kind of just starting to be more. Now I'm sure there's a little bit more education because the APTA even has like a special interest group, and you can become like a women's or pelvic health, like therapist, according to the APTA. So there's more awareness and things like that now. I don't know if there's any questions on the board about it. So again, the PT school doesn't want to spend too much time if it's not going to help their students pass their board exam. But even if it's just like a little bug in their ear, right? Hey, think about tongue posture, think about this, or think about how torticollis and the jaw, like, to me as a practicing provider and I see these babies, every pediatric PT should be comfortable working inside of the mouth on a baby with torticollis. Like, that to me should just be like a no-brainer, but it's not. So, but even if it's just a one-time guest lecture, I'm like, come on, PT schools, like we could do better by being more holistic instead of just teaching to the boards. But maybe one day we'll get there.
Yeah, I'm hopeful, and I'm sure it's going to happen because it has to. At one point, there will be no choice, so it's going to happen. So what would some red flags be for a parent? So you said clicking sounds when nursing. Oh gosh, I could name like at least 20 red flags I experienced with my son that I didn't realize were not normal issues. But what, like from a PT's perspective, what would some red flags be for that infant or early intervention population with nursing, bottle feeding, and not just feeding realm, but also any motor red flag?
So the first one would be head shape. I hear a lot of times where parents will call me and they'll say, well, my pediatrician referred me to go get a helmet, but I feel like I should look at PT too. And I'm like, so PT should be the first stop when you're looking at head shape abnormalities. So that's a really big one. PT will actually treat the root cause, like we discussed earlier. The poor body mobility is causing the head shape to be abnormal or concerned. So PT is first stop for head shape.
Could I ask, before we go on more red flags, can you talk more about helmets? So is that from a PT you would not recommend helmet, or could those head shape abnormalities be treated with physical therapy alone?
So it depends on the age and the severity of the head shape, but a helmet is not administered till at least the child's 4 months of age. Some insurances are asking for the child to, in order to cover the helmet, they're asking that the child have 2 months, basically 8 sessions of physical therapy before they will even cover the helmet, which sometimes I think is a great move on paper, but what often happens and what's happening now is that's being misunderstood as, oh, you can't get a helmet till you're 6 months, because that's when the insurance will cover it, because we noticed it at 4 and the baby can get one at 4, they get assessed by the helmet companies, and then the insurance is like, no, we want to see 2 months of physical therapy. And so then that takes us to 6 months. And so now pediatricians are saying, oh, you can't get a helmet till 6 months. Well, that's false.
That's crazy. That's a real misunderstanding. So people will go up until 6 months with no 2 months of PT. Okay.
Yeah.
That's not
so now we're getting them late in these instances, or we're just getting the wrong information out there when it comes to helmets. But again, the APTA is really doing a good job pushing patient consultants, midwives, pediatricians, anybody, as feeding therapists, anybody who sees head shape abnormalities, it should be an automatic referral to PT. We are not waiting and seeing. We're not telling the family, oh, turn your baby's head to this side, because guess what? Their pelvis is still tight. So it's still pushing the baby to look to their preferred side if you're not addressing it from a whole body standpoint. So then you have these frustrated parents that come in. They're like, well, I've been pushing my baby's head to this side, and they cry, and all they do is go to their right. They boomerang. That's what I call it. They boomerang right back to their preferred side. And I'm like, well, yeah, that's because there's other things going on. To be a little spicy, I didn't go to school for 7 years to tell a parent to turn their baby's head to the other side. There's so much more to that. And I think they're well-intentioned pediatricians. It's just, you can for sure tell the parent that, but then it's an automatic referral to physical therapy, because we can a lot of times avoid a helmet. So talking about helmets, you can't get a helmet till the baby's 4 months. So we could potentially have 2-3 months of physical therapy, conservative management. Once the baby is comfortable laying, at least in some, if we're talking about plagiocephaly, they have a side preference. Once they're comfortable laying in a supine, like nose to the ceiling, and or towards their non-preferred side, that's when I tell parents, now the time starts with, we should start slowly seeing head shape changes. But if that baby is comfortable looking to their non-preferred side, but they're still sleeping to this side, we're not making head shape changes. We need pressure on the rounded parts and pressure to be alleviated on the flat part in order to start making head shape changes. And again, it's pressure over time. So we're not going to see it in 2 nights. We're going to see a change in a week, 3 weeks.
Wait, question there. if a baby gets a helmet and they don't do any PT, and the helmet, by pressure of the helmet, corrects the head asymmetry, but they didn't get treatment for whole body, what do we see later as that baby's getting older? I don't know if there's research or common clinical things people see for
I've
babies
seen.
treated. Yeah, let's hear this.
Oh yeah, so I've seen, unfortunately, quite a few times where the baby got the helmet right at 4 months, and it's like, okay, we're being proactive. I didn't see the baby at that time. They didn't get referred to PT, and or the parent didn't follow through. The helmet was discharged at 6.5 months old because it was just a couple of months they needed it. Well, when the baby is 6, 7, 8 months, you can still make positive or negative changes on the head shape. And so the baby's head shape basically regressed. And so it was almost as if they didn't have a helmet. And so unfortunately, I've seen that because they didn't get the physical therapy. They didn't resolve the root cause. So once the helmet was discharged, they still had that body tightness, fascial tightness, and they went to their preferred side, and it got flat again as the baby's head continued to grow. So we have up until 12, maybe 14 months of age to make pretty significant impacts on head shape. It's not to say I don't refer to helmets at all. I do. It's just I prefer to get them earlier and earlier because a lot of times we can avoid them. And that would be the ultimate goal because they're expensive and they're hot. And, it's a lot of appointments. Parents are going every week to get their, the helmet looked at and modified. And so it's a big to do. It's not something that just go get a helmet and everything's fine. So I would love it if every single patient of mine could avoid a helmet. It's not always the case, but a lot of them we can.
And I would assume there'd be other whole body issues that continue to develop, or compensations. Because if we're saying the head turning preference and the flattening or asymmetry of the head is really due or has a huge factor of other parts of the body being tight or dysfunction. So you put a helmet on the head, almost like putting orthodontic appliances on an airway case, right? We're probably going to have relapse, but what happens to the rest of the body if it's not treated? Like, is that child going to have discoordination, reflex issues? I wonder, like reflex, not reflux, but like, asymmetry in their movement. Like, do you
Absolutely.
notice those things?
Oh yeah, it's usually, they rolled to one side. It's really hard. Sometimes I'll ask parents like, did they roll to both sides? It's really hard to catch it in the moment. Like, which shoulder did they roll over? So sometimes that goes unnoticed. But asymmetrical rolling is a big one. But with that asymmetrical rolling, now we have asymmetry of core strength and neck strength. And now we have asymmetry in the maturity of the vestibular system, which is the inner ear telling the baby what position they're in and if they're in motion and things like that. And so combo of the asymmetry of strength, asymmetry coordination, and now our vestibular system isn't developing appropriately and symmetrically. Is that baby going to crawl at 10 months? Sometimes they come in and they're like, they're not crawling yet and they're a year old. And I'm like, well, whoa, I put them in supine and the baby can't roll to both sides. And I'm like, well, here's our first problem. So we actually go backwards and work on rolling. So I see asymmetrical milestones that may or may not be picked up. I see delayed milestones because then the next milestone is that much harder when the baby doesn't feel stable on quadruped, on hands and knees, right? Or I see that hitch crawl with 1 foot flat and they're kind of scooting on their bum, or, babies are smart. They're going to compensate and get the job done. Just like with feeding, we might not, if we're not really honed in or trained, especially as a physical therapist, to know what the tongue should be doing on the breast or bottle, we can see compensations in a gross motor way. We can see that they roll to one side. We can see that they tighten up and log roll instead of have this beautiful spinal segmental mobility. We can see that they're bum scooting, right? So we could see these gross motor compensations. And in my opinion, if there's gross motor compensations, it often follows in the mouth. So a lot of times I'll see that tongue is really trying to elevate, but it's doing this. And so I'm like, there's something pulling the tongue down on that one side for it to elevate, in this asymmetrical kind of like diagonal line almost. And some parents will notice it, but a lot of times they won't. They don't know that they're supposed to look at their tongue mobility and how it's supposed to elevate when the baby cries or how wide their jaw opens. And I mean, I have pictures of my daughter yawning and she literally had like asymmetrical positioning of her mandible while yawning. And I was like, my God.
The same thing for my son. I mean, there's pictures I think he still has that a little bit when he yawns. I can see the jaw goes a little bit to the side. None of that was treated at birth, but I could see it. I didn't know then that that was a thing. I just thought, oh, look how cute his jaw goes off to the side. Like this, like I have an image of a picture of him yawning with his jaw shifting. I mean, who would have thought back then? Now we know. I mean, I wish you were around. Like I knew you 12 years ago. You could have helped me so much. Really crazy. Yeah. And I also feel like the compensations that develop, it's that cascade, right? If we're not treating that root cause, that underlying, not only are there issues with the rolling, the crawling, the walking, but then when that kid is ready to play sports, maybe they don't want to play sports because they're not good or they can't throw a ball or turn. Maybe in the classroom, handwriting is difficult because there's core strength issues or head turning preference. Maybe now they don't look, their vision might be impacted because they can't look straight at the board. Just really interesting. So your role is so important. And I know I kind of shifted us off topic, but we were talking about red flags for like infants, and that head shape just got me because I don't know so much about these head shape issues and helmets. And I really feel like I know so much more now. So that's really good information. So a head shape asymmetry abnormality would be a big red flag for an infant or a young child. What other red flags do we see that would warrant a PT inspection evaluation?
Sometimes parents will say, oh, they're right-handed and they're like 3 months old. So handedness doesn't develop until long after. I mean, even 3-year-olds are eaten with 2 spoons, so I would even push it further. And my OT colleagues can be a little bit more specific than I can, but I'm like 3+, we should be using and developing both sides of our body and not having a hand preference. But basically just, my baby hates tummy time. Yes, most babies initially right off the gate, are going to be slightly uncomfortable in tummy time, but it's now we're getting into 3, 4, 6 months and they're still hating tummy time. That's where we have to say, okay, something's going on. It doesn't need to be a big, huge looming diagnosis, but something's going on that needs a closer look, because we should be pretty comfy, confident in tummy time at 3 months, if not sooner, 2 to 3 months. And then those developmental milestones, not rolling on time, not sitting, crawling, walking, all of those not meeting those needs. But when it comes to feeding and behavior in the young infant, we scream every time we position the baby to breast. Okay, well, we don't want a dysregulated baby that's about to feed. And even feeding behavior, and I know my sister won't care if I use her as an example, but all 3 of her kids had severe oral restrictions. She did not do the got a tummy tie release for the first 2, and for the 3rd she did. So she experienced both as infants. And she said when she got her 3rd baby release, she said, wow, he doesn't want to feed every hour. And I said, yep, that's good. That means he's satiated. That means, he can go 2, 3 hours between feeds. And she's like, yeah, and he sleeps for like longer chunks of time. And I'm like, well, what do you mean? Well, he'll sleep for 4 or 5 hours before he gets up to want to feed again. He's just not a snacker like my other 2. And I'm like, well, that's dysfunctional. A snacking baby within reason. They go through growth spurts, but all that should be temporary. If you have a mom that's like, oh, they want to feed every hour to 2 hours and they're 3 months old, to me, that's a red flag. So these parents and pediatricians, when they're talking in the office, they don't often know that feeding schedule isn't typical. That's not what a parent should have to do in order to keep their baby well nourished and fed. And we're not asking those questions in the office. And pediatric PTs as well. We get a baby with torticollis. We're not asking about feeding, but why aren't we? We should be, and we should ask. My favorite question to ask is, what does a 24-hour period of time look like for you and your child? And that's going to tell me a lot when it comes to positioning. Oh, we have to put him in the car seat to bring older brother to all the sports and activities. Okay, he's in a container a lot. Or that's going to tell me first baby, these parents are just trying to keep afloat with weight gain, and they're feeding them every hour and a half. So that to me is a huge red flag. And then of course you get the babies that are screaming and then have these reflex-like behaviors, gassy, they're grunting all the time. They just don't seem comfortable. That's a red flag to potentially that movement in the sand, where we need to move the sand for the baby so that they feel comfortable in all these positions. And just, sensory integration. if you take continuing education courses on sensory integration, they talk about like school age and up or toddler and up. They don't talk about an infant. And for me in my practice, that's huge to get these babies' nervous systems regulated. You can have a slow birth and have a baby that's dysregulated, and you can have a really fast birth, or you can have a C-section baby. So to me, the birth, I'm like, okay, good to know. But I've seen dysregulated babies with all types of births. And if they're not regulated, they are not ready to learn. And learning is, feeding. You learn when you feed, you learn when you move, you learn when you play. So dysregulation at baseline is just my baby. It's just colicky. Colic is just a garbage term for, we don't know why your baby's crying, but they cry a lot. So colicky babies are in my office a lot. Dysregulated babies, trouble feeding, pain with breastfeeding. Breastfeeding should never be painful. If it's pinchy, pulling, I've heard razor blade, I've heard clothespin-like pinching. That's never normal, ever, ever, ever. It can feel, what is normal and what some people say, oh, breastfeeding is just painful, is just a little bit of like, oh, something rubbed across my nipple, not pinching, paining. So we can talk about the science of pain, and we could say, oh, this kind of discomfort for your nipple sensitivity is typical and that will alleviate with time, but this kind of pain is not. So pain with breastfeeding is a big one, or a breastfeeding preference, which can be lactation. It could be caused by a lactation type of issue, but a lot of times it's the baby's asymmetry that's causing that preference.
What kinds of like manual or hands-on work do you do with these infants? I can't picture, like, what is a PT doing and what are you doing in the mouth?
Yeah. So, going back to when I graduated from PT school, I considered myself a manual therapist. I went to a school that was very heavily, we learned so much with our hands. We learned osteopathic techniques for the nasal bone. We did so much more than a lot of the other schools out there, just because that was the focus of the school. So I considered myself a manual therapist when I graduated, and I got out in the field and it was like, oh, you're a pediatric therapist, so you're a neurotherapist. It was very much how our medical system works, right? Where it's like in silos. And it's like, oh, then you do neuro. And I was like, no, I'm a manual therapist. And they're like, oh, no, if you do peds, you do neuro, which there's a lot of neuro issues with the population that I see, right? But there's also a lot of fascial strain and muscle, just tightness, and tension is kind of just like a regulatory whatever word. It's not really a medical word that we were taught to use in PT school, but it's just restrictions in motility of soft tissue. And what soft tissue is that? Is it fascia? Is it muscle? Is it ligamentous? Is it tendon? Like, what is restricting this baby's ability to move well? So I did a lot of manual therapy work, and I was kind of the outlier. And then I kind of found this airway tug tie space, and I finally felt included with my PT colleagues. I was like, oh, these are my people. They're doing manual therapy on infants. Yeah.
Yes.
So, it really depends on the provider. Me, myself, I do a form of craniosacral therapy that's called craniosacral fascial therapy. I do some counter strain. I do total motion release, which is a little bit more osteopathic type of manual treatment to relieve extra, restrictions in the fascia and muscles. And then I do a lot of manual, joint mobility, massage, myofascial release, so there's a lot of types of trainings that I've taken, and I just kind of put them all together. And then it sounds hooky or weird, but I just feel with my hands and I'm like, oh, this would be good to kind of incorporate this and this. So I just kind of incorporate a bunch. There's no like, oh, I always do this or I never do this. So
it's a lot. It's a lot of different things to do. And I like that point that it's not all neuro. That hands-on is so important. I mean, honestly, for any age group, hands-on is such an important aspect. You can't tell people to do things without actually helping guide them, releasing tension, whatever it is. I see that's a really important component to treatment at any age. And I've seen pictures of cases you've treated, which are these amazing pictures of how you and the OT have worked together to help relieve tension. I want to hear about how you do this. And I've seen babies born with incredibly recessed mandibles. And I look on photos of my son, I'm like, oh my God, his lower jaw was so far back. but you've worked with them for not too long periods of time, and that lower jaw has caught up in growth and has grown forward. So please talk about that.
Yeah. So, we first have to think about when it comes to that recessed mandible, something is causing it to be positioned further back into the airway, and that's not a good thing. And so what's pushing it back? I mean, I don't know that I could, exactly identify every single structure, muscle, piece of fascia that is, but what I can tell you is it's a combination of things typically when it's that intense, like the picture you saw. So for, those babies, I have to think, okay, when it comes to bone and soft tissue and when they're not in agreement, the bone wants to grow forward, right? So the mandible does want to grow in a PA direction. It wants to grow anterior, but something's holding it back. So when it comes to soft tissue and bone, soft tissue will always win. It will stop the mandible from growing forward. And bone will be like, okay, I'm listening to you, soft tissue. So that's where my hands come in, and I'm like, okay, what is holding this jaw back and locking it back into this airway? And how can we relieve any of that extra strain on that mandible and also maxilla, but mandible in this particular case, to allow it to grow forward? It wants to grow forward. It's just something stopping it. So I'm looking a lot at the supra and infrahyoid musculature. I'm looking at, really the whole picture when it comes to, like we talked about before, body coordination, muscle firing patterns, strength, symmetry. I'm looking at the jaw to make sure it can drop open for breastfeeding, because we know that if the child is breastfeeding, bottle feeding a little less so, but if the child is breastfeeding and has optimal mechanics, that jaw will come forward. And that's because the mid blade of the tongue has to elevate and cup around the breast tissue. And if that mid blade of the tongue isn't elevating and it's just the tip of the tongue, it's not going to help the mandible come forward. So part of it is teamwork. That little guy that you saw had me on the team, occupational therapy to normalize tongue mobility, and also had a tongue and upper lip release. So we released the structural issues. He did have a high palate as well. So we had some structural issues that we had to continue to kind of work against, basically. But once the tongue had more mobility, the OT worked on improving tongue strength, endurance, coordination to improve breastfeeding. And then I worked on the ability for the jaw to open, the ability for the body posture to be in the most advantageous position to breastfeed, so breastfeeding is successful. And then the repetitive act of breastfeeding and time with growth allowed it to come forward.
So that soft tissue, by relieving the soft tissue, gaining appropriate mobility, that soft tissue is no longer holding the lower jaw back. The picture is amazing. And I've seen a few of your cases like that, where that lower jaw just comes forward, and it almost looks so recessed, like almost syndromic sometimes when that lower jaw so far back. And it's amazing the work you guys can do with that, because that is the key to get these kids on the right track, and it gets missed so often. So I kind of want to wrap up talking about I have two things. Let's see. One is maybe tips for parents or even providers who are working with little babies, anything to help with better posture, gross motor, helping to prevent future issues. What would you tell parents? We talked about red flags, but you also talked about decreased container use, movement, tummy time. Anything else you would want to add to that?
I think when it comes to parents is, reaching out to any specialty provider just to make sure things are okay doesn't mean that your baby's going to need a bunch of therapy. Doesn't mean that there's anything wrong. I mean, I have some parents that are just so hesitant. Like, I don't know, why would my baby need physical therapy or feeding therapy? If I see the baby and I'm like, okay, we need to see a feeding therapist, they get a little bit hesitant. We're like, well, my pediatrician didn't tell me that this was necessary or this or that. And so I think a big part of it is sometimes it is just wellness. Your pediatrician or your primary care doctor is going to make sure you're surviving. And that's the level of care here. And then me and my colleagues who work in this airway space, tongue ties, what have you, we're going to make sure that your child is thriving. And so there's a difference between surviving and thriving. Surviving is compensatory things like my daughter, she clicked for an entire year of breastfeeding. I breastfed her for 12 months. She clicked the entire time. I knew she wasn't supposed to, but I didn't really have the support and the providers in place to make sure that she was thriving. And then she needed a palate expander at 3, and then a tongue-tie release at 5. So, and lots of speech, and myofunctional therapy and all the things. So, had I known back then what I know now, I would have made sure that she was thriving, not surviving. And so the primary care providers are well-intentioned, but they're just checking it off and make sure your baby's well-nourished and developing milestones. So there is a difference between surviving and thriving. And that's kind of like the talk that I give some of my parents when they're just not quite sure what to do with the information I give them, or I don't know if I'm ready for a tongue-tie release. I said, that's okay. It might come about at a later date, like it did for me. Most often it will, whether it's when they're 5 or when they're in their teens, or when they're an adult and they just busted their TMJ. Anyway, so, I wanted to decrease the stigma around getting therapy for your child, because it's really just to help them thrive. That's my first one. My second one is get a second opinion. If you feel like your voice isn't heard, it's probably not. And it's probably that difference between surviving and thriving. It's, again, that 24-hour period of time of I'm feeding my baby every hour. Their weight gain's fine, so nobody has said anything. But that is not okay for long periods of time, to have to feed your baby every hour, or to sit them up for 45 minutes after every feed, or whatever compensations these exhausted parents are doing. So get a second opinion. When it comes to providers, I really think that not thinking that evidence-based practice is just your perfect, randomized controlled trial, because our experience in our clinical, what we see every day is still part of evidence-based practice. And if you're only practicing to those randomized controlled trials, you're practicing 10 years behind. And that's evidence-based.
that is true. So how do people find amazing physical therapy providers like you for this early intervention age group? We know you're in San Diego, but is there a website or resource for other people to find you, people like you to team up with, or for parents to find that help?
There's a couple of websites out there that's a little bit helpful. They're just not, there's not one that I'd be like, oh, go to this one. So Airway Circle is a great one that has a lot of listed providers out there. But basically, when you are trying to find a provider, I would just ask, do you treat fill in the blank? Do you treat babies? Do you do manual therapy on babies? Manual therapy is our terminology for our hands-on approach as physical therapists. If you're talking about a massage therapist, it might be myofascial release. If you're talking about a chiropractor, it's going to be adjustments in soft tissue. So a physical therapist, we say manual therapy. Do you do manual therapy on infants? Are you familiar with feeding difficulties? Are you familiar with tongue ties? So it's really just making sure that independent provider, because I don't have a great one website that's like, oh, it has all my peeps on it.
Yeah, that makes sense. I think with most fields, just asking, like you said, do you have experience with blank, and how much experience you have, just talking to the provider to see what experience, what courses. Really great. This was so informative. I want to just do a little summary before we end, because I take so many notes and my notes are a mess. Now I'm like, because it's just so much great information. So I'm going to talk about some of the things we covered today. We talked about containers and how babies shouldn't be in a single container for more than about 15 minutes at a time. We want to get our babies moving, crawling, rolling, the importance of tummy time. We also talked about torticollis, meaning a head turning preference, which could cause issues like plagiocephaly, which is a head-shaped abnormality on one side, or brachiocephaly, which is a flatness on the back of the head. We talked about causes of that, and it's not just issues with the SCM or neck, but also issues with whole body, from core to diaphragm, rib cage, and looking at the entire body, which not all pediatric PTs are actually looking at the entire body, but pediatric PTs might be really focused on the SCM, head and neck, with babies with torticollis or head turning preference issues. We also talked about different red flags that a parent or a practitioner IBCLC, anybody working with babies might notice these things and have to be alerted that these could be an issues, like the head shape abnormalities, handedness issues before age 3, or handedness, like a hand preference before age 3 is not really normal. Babies rejecting or having a really hard time with tummy time after about 2 to 3 months would be a red flag, like an aversion to tummy time. Rolling, crawling, walking issues, missing those milestones, feeding issues. We talked about a variety of feeding issues, sensory integration issues like colicky, dysregulated babies as well. We talked about soft tissue will always win. And that talked about whole body, oral cavity. And a good question to ask a patient is, what does a 24-hour period look like? That's a really good PT question to ask a patient, the mother of, or the parents of these infants, to really get a grasp of, wow, you are spending nonstop time nursing your baby because they're not getting satiated. Like, these are things we need to look into and ask about. So that's a great question. I learned also about helmets that a lot of insurances require 2 months of PT, and anybody who has a baby with an abnormality of head shape should see the PT first before going the helmet route. PTs can do a lot for that without helmets, or if a helmet is needed. Also, torticollis issues, we should ask about feeding. That's a really important direct link, feeding issues and torticollis issues. Parents should just reach out to providers, ask questions. Don't be afraid. Don't think that, oh, your baby's seeing a PT, there's like some major problem, but we want to have our kids thrive. Not just survive, but thrive. And I think any parent would be on board and agree with that. Yeah, Dr. Hope, this was so wonderful. And if I'll put your information in the notes if people want to contact you with questions. And I really thank you for all you do for the babies, little ones out there, and for helping educate everybody. So thank you so much for being here.
Thanks, Nicole. Have a good day.
You too. Bye. Thank you so much for joining this episode of Airway Answers. I'm hoping some of your airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info, or check out our site at www.airwayanswers.info. Thank you so much, and join us for the next one.